Welcome back, my dears. You've tuned into your menopause, your way now and for the rest of your life. And I'm Menopause Taylor, making sure the rest of your life is the best of your life. In fact, we are in the middle of a great big unit on one of the things that could really mess up your life, osteoporosis. In my book, Osteoporosis is all of chapter 29, regardless of whether you have the first edition or the second edition. We started this unit in video 196, and now we're here at video 208. I've taken you through a stepwise understanding of osteoporosis. So here's what you've learned so far. Osteoporosis means bone loss that is due to estrogen loss. And when you lose your estrogen, you have very rapid bone loss in the first 5 years of post-menopause. But there are no symptoms to tell you that you're losing bone. So the very first indication is usually a fragility fracture of your spine, hip, or wrist from normal things that would never cause a fracture if you had enough bone. So there are devices for determining how much bone you have. The gold standard is the central DEXA bone density test. The problem is that the guidelines for getting it defer the very first one until you're 65. And by that time, you could have lost a bunch of bone or even had a fracture already. And even though there is a huge list of risk factors for osteoporosis, most women don't know what they are. And most doctors prefer to rely on risk assessment tools to assess who is at greatest risk for fracture. So today, we're going to discuss risk assessment tools for osteoporosis. If you recall the unit on heart attack, there were risk assessment tools for heart attack too. So if you're wondering why you need to know about risk assessment tools for osteoporosis, it's because even though they exist, they are not what you think they are, and they are not as nifty as they sound. Let me warn you from the start. If you have not watched the osteoporosis videos that precedes this one, you probably won't understand this one. All of the osteoporosis videos that come before this one are important for this one. There's just no way to give you this material in anything other than a stepwise manner, and that's why it's important to watch the videos in order. Let's start by designating your reasons for wanting to know if you have osteoporosis. You want to know if you're at high risk for sustaining a fracture that could change your life forever in a substantially negative way. But the guidelines dictate getting your first bone density test at age 65. And getting your first bone density test at age 65 misses the boat on making sure you avoid a fracture. So the guidelines do not serve your needs. In video 206, you learned that when you do get a bone density test, the central DEXA test gives you 2 scores. The T score compares your bone density to that of a 30-year-old woman, which is the age of peak bone mass. So it serves your needs in telling you how much bone you've lost since the age at which you had your peak bone mass. But even though the truthful T-score is a true indication of how much bone you've lost, some women still sustain fractures before they reach a T-score that is in the range of osteoporosis. And the zany Z-score compares your bone density to that of a woman of your same age and ethnicity. In other words, it shoots for mediocrity, so it does not serve your needs. With so many women getting osteoporosis and having fractures, the last thing you want is to be like the average woman with regard to bone density. Then in video video 207, you learned that markers of bone loss in your blood or urine are useless in helping you determine your risk of fracture. So they do not serve your needs for knowing that you have osteoporosis before you sustain a fracture. In essence, you have a disease that produces no symptoms until you fracture a bone. And what you want is a tool that can predict your risk of fracture before you fracture a bone. So all of these inadequacies in the devices I've presented so far are the reason that risk assessment tools were developed. So now let's see how well they are able to serve your needs. In video 206, I showed you this. It's the scale used for determining who has normal bone mass, osteopenia, and osteoporosis. And the ranges indicated are called T-scores. So a T-score of 0 and above indicates a normal bone mass. A T-score of negative 0.1 to negative 2.4 indicates osteopenia. And a T-score of negative 2.5 and lower indicates osteoporosis. Based on that scale, you would expect fractures to occur only in the women who have a T-score below negative 2.4. In other words, you would expect those categories to designate who is liable for a fracture. But alas, this is not the case. It turns out that most fractures occur in women who have T-scores in the osteopenia range. So you want a risk assessment tool that targets your risk at a point on the T-score scale when you can still prevent both osteoporosis and fractures. You want a tool that focuses on the yellow section, and the earlier, the better. So this led the World Health Organization to develop something called the Fracture Risk Algorithm Tool, or FRAX tool, F-R-A-X. Now, an algorithm is merely an equation or a set of rules. In the case of calculating your risk for a fracture, it consists of applying a formula to your data to see where you fall on a scale of risk. The goal of the FRAX is to use clinical risk factors, which are all the things I presented in video 203, with or without your T-score, to generate your probability of having a fracture from osteoporosis in the next 10 years. FRAX relies on economic models to determine your 10-year risk of fracture, above which it becomes cost-effective to start medical treatment. Now, let's dissect what I just said. I just told you that FRAX combines your risk factors and your T-score to give you a probability of having a fracture of your spine, hip, or wrist over the next 10 years. Now, depending on your situation and preferences, you may like the fact that it's designed to give you your risk over the next 10 years. Or you may find it a bit less useful simply because it distributes your risk over the next 10 years. But the part of my statement that came after that is what's really important. I said that FRAX relies on economic models. Whenever you hear the word economic, think money. In the case of a risk assessment tool, think in terms of how much money is allocated for the disease in question. So this entire FRAX tool is based on a monetary limitation. And it's a monetary limitation on how much money is going to be spent on the entire population. That automatically limits its utility to you personally. You don't care about the entire population. You just want to know how likely it is that you will sustain a fracture. But this tool is all about whether or not it's cost effective to treat you if you have low bone density. In essence, it determines whether or not it's worth spending money on you. And the last part of my statement was the phrase, above which it becomes cost effective to start medical treatment. What? Treatment? Did you think this risk assessment tool was about diagnosing osteoporosis or about treating osteoporosis? You see, that's a huge distinction. If you aren't a medical professional, you could very well be misled as to the very purpose of the FRAX tool. Most of us want tools that serve as screening tests. A screening test tells you whether or not you have a precursor to a disease so that you can prevent the disease. Or it diagnoses a disease very early so that you can eradicate it. You might recall video 206 when I made the distinction between prevention, early intervention, and fixin'. In that video, I showed you this. We would all prefer to discover our bone loss in the low normal green range or in the early intervention yellow range. And the whole reason for creating risk assessment tools was because neither this T-score scale nor the guidelines for getting your first bone density test accomplishes that. And based on this terminology, it's apparent that the same is true of the FRAX risk assessment tool. In other words, it doesn't target prevention or early intervention. It's designed to determine who needs fixin', which is in red. So the FRAX risk assessment tool is for purposes of determining not if you have osteoporosis, but if you are eligible for treatment for osteoporosis. There's a big difference. For instance, your pap smear tells you if you have abnormal cells on your cervix, and if you do, you can have them treated early so that they never ever become cervical cancer. And a mammogram tells you if you have an abnormal area that could be cancer or become cancer in your breast long before it's large enough to feel on a self-breast exam. And if you do, you can have it treated so that you don't die from breast cancer. Pap smears and mammograms are screening tests for diagnosing these diseases early. They fall into the prevention and early intervention realms. But as you saw in the unit on heart attack, the goal of risk calculators for heart attack was to give you a probability of having a heart attack over the next 10 to 30 years. And here, with the FRAX risk calculator for fracture, it gives you your probability of having a fracture over the next 10 years. So what you're seeing with risk assessment tools is that they focus on the probability of your needing fixin'. So they are not tools for prevention or early intervention. They are tools to determine who has such advanced disease that they need fixin'. So FRAX is for fixin'. But the big key is to know how it's used in practice, because the FRAX tool is designed to determine who gets treatment, and therefore it can be either beneficial or detrimental on an individual basis. Now the good thing is that there are different FRAX algorithms for different categories of women. The United States has different algorithms for white women, black women, and Asian women, which, as you learn in video 158, are all considered racist. And it has an algorithm for Hispanic women, which, as you also learned in video 158, is an ethnicity or a nationality, but not a race. But the FRAX risk assessment tool also has drawbacks. When I gave you all the risk factors for osteoporosis back in video 203, you saw that the list of things that put you at risk is very long. Here it is. On that list, there are 19 major categories and many subcategories for 2 of those major categories. And there are dozens of things that constitute secondary causes of osteoporosis that are not even on that list. A secondary cause of osteoporosis is any other disease that puts you at risk for osteoporosis. So let's see how many of these factors the FRAX tool includes in determining your risk of fracture. The United States FRAX tool includes all of the following: age, gender, weight, height, personal fracture history, your parents' fracture history, smoking, alcohol, use of steroids, rheumatoid arthritis, and secondary causes of osteoporosis. Of those, here are the ones that are on the long list of risk factors I gave you in video 203. They're highlighted in red. So, FRAX takes 6 of the 19 risk factors into account. And did you notice that the T-score is not included in the assessment? The T-score is optional. There is room in the algorithm for the T-score if it's available, but it's not a requirement. I think it's odd to develop a risk assessment tool that is supposed to compensate for the limitations of the T-score and not require the actual T-score. Don't you? The FRAX tool has been developed for different countries to take into account different risk levels for different cultures, and that's a good thing. Here are the women who are eligible for treatment based on the FRAX tool. 1, women who have a 20% or higher 10-year risk of any kind of fracture. 2, women who have a 3% or higher 10-year risk of hip fracture. And 3, women who have already sustained a fracture. Now, depending on how you interpret those numbers, you could find these eligibility for treatment requirements satisfactory or unsatisfactory. For instance, a 3% risk of hip fracture sounds like a very low threshold for treatment. But remember, guidelines are not about you. They're about the whole population. So if you have to reach a 10-year risk of 3% before you get treatment, it means that for every 100 women who do receive treatment, 1.5 of them will have to fracture their hip first. In essence, the FRAX tool uses your data but calculates your probability of fracture according to population statistics. The health industry, or more accurately, the disease industry, may consider that acceptable, but do you? What if you're one of the women who has the hip fracture? Does that change your opinion? What I'm getting at is that there is a big difference between prevention and fixing. No risk assessment tool focuses on prevention. They all focus on fixing in terms of the entire population. Not one of them cares a fig if you sustain a fracture, but I do. That's why I present these videos to you in a way that enables you to make use of the information in a practical way. While this nifty tool is nice, there are obvious problems with it. First is the fact that doctors are restricted to using the Frax tool only for women over the age of 50. If you really want to determine who needs treatment, why have an age limit? You learned in video 200 that young women who are prematurely postmenopausal are at high risk for osteoporosis and fractures. So the age limit of 50 does not serve them well. Second, the Frax tool only makes bone density test results optional. And even if you have bone density results, it only uses the T-score for your hip. It totally ignores your spine. What if you have osteoporosis in your spine, but normal bone density in your hip? It turns out that the first bone loss in early postmenopause is in your spine, not your hip. If that's the case, it won't serve you well because the results would be likely to advise against treatment. Third, the Frax simplifies the list of risk factors and only takes a few of them into account. It doesn't include a history of anorexia. What if you've battled anorexia your entire adult life? Even if that were your only risk factor, it would be significant. But if your Frax score didn't take it into account, it would put you in the no treatment category. Fourth, there is no way to take quantities or dosages of risk factors into account, including alcohol, tobacco, and steroids. All of the data for those is in simple yes or no format on the Frax form. Fifth, the only secondary cause of osteoporosis that is included in the Frax tool is rheumatoid arthritis. Not only are there many different kinds of arthritis, there are also many other diseases that cause osteoporosis. Sixth, the Frax does not assess any of the factors that increase your chance of falling, of which there are many. Seventh, you are not allowed to use the Frax tool if you are already taking any kind of medication to prevent or treat osteoporosis. Eighth, the Frax tool only takes parental hip fracture into account, not spine fracture. So if your mother fractured her spine, it doesn't count. All of these limitations make the Frax tool fairly inaccurate. You saw the same thing with risk calculators for heart attack. Sometimes it's just better to know the list of risk factors and do everything you can to lower each one of them. Now, Frax is not the only risk assessment tool for osteoporosis. I mean, you know how it is. When a new gadget appears, everyone starts copying it. So here are some of the names of other osteoporosis risk assessment tools. There's the United States Preventive Services Task Force, USPSTF strategy, which only identifies 1/4 of the women who are at risk. There's the Garvan Fracture Risk Assessment Tool, and there's the Osteoporosis Self-Assessment Tool, or OST, which is for determining who gets bone density testing. And all of these risk assessment tools result in inconsistent recommendations as to who is at risk for fractures and who deserves treatment. Anytime you are talking about risk, you have to realize that there are different types of risk in the statistical sense. So when you get results from any risk assessment tool, it will give you your risk in terms of a percentage. But do you know how to interpret that risk? Most people don't. There are two basic types of risk in terms of statistics: relative risk and absolute risk. Relative risk is the risk of a fracture in a woman who has a particular risk factor compared to women who do not have that risk factor. Absolute risk is the risk of a fracture in a particular woman, period. The easiest way to explain the difference is this. Do you know the best way to increase your chances of winning the lottery by 100%? Buy a second lottery ticket. So if you buy 2 lottery tickets instead of just 1, your relative risk or chance of winning the lottery doubles. That may sound like a big increase in probability, but your absolute risk of winning the lottery is still only about 1 in a million. When it comes to creating risk assessment tools, the kind of risk used to make decisions is the relative risk, not the absolute risk. You're probably more interested in your absolute risk. So be careful about interpreting the results of any risk assessment tool. Personally, I think it would be a whole lot better to let you decide if you want prevention or fixin'. All it takes is education. And that's precisely what I'm doing with these videos. If you know the whole list of risk factors, and you know that there are no symptoms of osteoporosis, and you know to get your bone density tested early, if your bone density is low, you can decide if you prefer to pursue prevention, early intervention, or fixin'. And you know I'll be giving you all your options for doing all 3 right here on this channel. So to summarize what you need to know about risk assessment tools for osteoporosis, they are algorithms that take only a few risk factors for osteoporosis into account. They give you a risk of fracture over the next 10 years, but they are fraught with limitations and flaws that make them fairly inaccurate. And that's where we'll end today. Now, next week, we'll address premature menopause and osteoporosis. Don't miss that. Schedule a consultation anytime at menopausetailor.me and I'll help you with anything. Be sure to follow me on Facebook, Instagram, and Twitter, and subscribe to my channel. Bye.